really knock someone out to take away their drive to breathe. They may lose their airway, but in an intubated patient, that's not such an issue. But what they found is that by adjusting the ventilator, they were much more effective at achieving synchrony. And what did they do to change the ventilator? Well, they either changed the mode or they changed the inspiratory time. And here's an example of a patient. Again, they were looking at asynchrony, lots of double stacks for this patient. And what they did is they added an inspiratory pause. So they increased inspiratory time without changing flow, right? Flow was kept at 60, but then they put an inspiratory pause in there to increase the inspiratory time. And noticed that the patients developed lack of breath stacking. Their breath stacking went away by putting in that inspiratory pause. Again, this still doesn't make sense to me. That seems very unphysiologic to take a breath, pause before exhalation. But again, you know, the data is pretty clear that it helped these patients get much more synchronous with the ventilator. The other thing they did is switch patients to pressure support ventilation. And again, synchrony went away. So, or excuse me, asynchrony went away. Patients, their breath stacking went away. But unfortunately, what happened is their tidal volume increased. Rather than the 400 cc's per kilogram that we wanted, they were still getting, you know, 800 cc's. Or excuse me, that their breaths were 550 cc's, which is better than the 800 they had when they were asynchronous with the double stacking, but still not the 400 cc's that we were hoping to achieve for lung protective ventilation. So certainly switching to pressure support will increase synchrony, but may not achieve all the goals that we're trying to achieve. That addition of an inspiratory pause, an interesting, and again, not fully understood mechanism, increases synchrony for the patients. Again, looking at what I just showed tracings of one patient. This is looking at all of the patients that they studied in one time. Again, changing to pressure support from assist control to pressure support ventilation resulted in an increase in tidal volume of about 4 cc's per kilogram of ideal body weight and an increase in inspiratory time. Whereas changing the inspiratory time and remaining on assist control, volume control ventilation did not result in a change in tidal volume, but again, increased inspiratory time. Also, increase in tidal volume was effective in decreasing synchrony, but again, increases tidal volume. So may not be achieving the goals. So again, increasing inspiratory time through an inspiratory pause seems to be the most effective way to increase synchrony in patients with double stacked breaths. Again, the extreme of cycle asynchrony for our patients. Again, how much inspiratory pause? Not a lot of science there yet, but usually about 0.1 to 0.2 seconds. Less than 0.1, and you may not be achieving very much. And also the subtle danger of a very short inspiratory pause. Sometimes people use that inspiratory pause as a way of continuously measuring plateau pressure. And with a very short inspiratory pause, you may not achieve plateau pressure yet. The number that comes out on the machine may be halfway between the peak pressure and the real plateau pressure because it hasn't had enough time to decay to the actual plateau pressure. So short inspiratory times can be dangerous in that way, in that it's providing you with inadequate information or inaccurate information. Longer inspiratory pauses, longer than 0.2, 0.25 seconds, again, is increasing inspiratory time, therefore decreasing time for exhalation and the risk of auto-PEEP. Just a couple more patients to think about. Again, low-tech images with my reflection on the screen. This patient has influenza, MRSA pneumonia. They have a blood gas of 7.32 for a pH, PCO2 is 28, and PO2 is 63. And so what do you see? Trigger asynchrony, okay. I see flow asynchrony. I see cycle asynchrony. I see all sorts of asynchrony. Lots of asynchrony going on here in this patient. So what do you want to do? What's one change that you can make for this patient that can make all those asynchronies go away? Okay. So I hear some whispers of inspiratory pause. Good, you've been listening, all right. But someone said there's a little bit of trigger asynchrony there too, so increasing inspiratory pause will decrease exhalation time and therefore risk that, all right. Okay, so that'd be a problem there, and also increasing the inspiratory pause, inspiratory time. The inspiratory pause is going to get rid of this, but I also see flow asynchrony. So if you increase the inspiratory time some, you may lose some flow unless you do the inspiratory pause that Ryan's whispering over there. I can read your lips. We'll talk later. Actually, probably the thing that I would do for this patient is actually to increase their respiratory rate. We said respiratory rate average 29 for patients with ARDS. So this person's average, but has a lot of asynchrony. Let's increase their respiratory rate, increase their rate up to 38. You have one breath that doesn't look so good there. But the majority of those breaths, the flow asynchrony seems to be going away. The cycle asynchrony, still not gone, but much, much better than it was before. Again, increasing the respiratory rate from 30 to 38 helped many of those asynchronies go away. Again, reasons that we use seemingly very, very high respiratory rates, but that helps with asynchrony and therefore helps decrease the injurious lung patterns that we see with asynchrony. And again, this is another example. If I go back a slide, this person's blood gas, pH 7.32, PCO2 of 28, might not lead you to say, let's increase minute ventilation. Minute ventilation based upon gas exchange doesn't look that bad. When you look at the ventilator graphics, you say, boy, we need to increase this person's ventilation delivery because we're not meeting that patient's demands. Finally, patient, 50-year-old woman admitted to my ICU with encephalopathy. This person's wearing green, so you know it's not me taking the picture, or teal, whatever color our respiratory therapists wear at the University of Iowa. So this is a patient brought into the emergency room, intubated in the emergency room for encephalopathy. And what do we see here? Very low flow, thank you, right? Really long inspiratory time, well over a second. And peak pressure still 24. And someone may have said some flow asynchrony there too. And certainly I do see that. So the story on this patient was intubated for encephalopathy. For whatever reason, the endotracheal tube was kinked shortly after intubation, resulting in really, really high peak pressures because there was extreme resistance to flow. And someone said, well, I don't like those peak pressures, so I'm going to decrease flow. And that did decrease the patient's peak pressure by decreasing the flow. But unfortunately, then that results in really long inspiratory times and flow asynchrony. And again, did we even need to decrease that person's flow? Was the elevated peak pressure a problem? In this case, we know it was because of a kinked endotracheal tube, so we know that. What's interesting in this flow pattern, and I didn't talk about this so much, the pressure pattern, is where we see the bend in the inspiratory flow, and in this case, the bend is very, very high. So the difference between the bend and the peak pressure is very low, and that suggests that this person's difference between their plateau pressure and their PEEP is also very low. So this person, if we measured it, and I don't have a screen that shows it, this person's plateau pressure is about 12 with a set PEEP of 5. Again, despite really high peak pressures, their plateau pressures were normal because we had a normal lung in an encephalopathic patient. So the attempt to change peak pressure by adjusting flow really resulted in asynchrony for the patient without fixing a problem that was meaningful to the patient. Sorry. All right, changing modes, pressure support, ventilation. What sort of things do you see looking at this person's pressure tracing and flow tracing? This doesn't look like pressure support, really. This doesn't look like very good pressure support, right? Looks like really bad pressure support. But given the things that we just talked about, what's going on in this patient, all right? Despite having a pressure support set, their pressure that's actually achieved is actually much lower than the set pressure. And why would that be? Patient effort, right? Patient effort is pulling that pressure down lower than what your set pressure is. Why is that patient pulling so low? Well, again, because we're not giving them enough pressure. But the issue there is, looking back at flow again too, so here's flow of 60 as the top of the graph, so this person's flow on that pressure support is about 45, and they're not happy about that. And so they're pulling a lot harder, trying to get more flow for their patients. So how do we treat this one? And you guys all know this. Increase the pressure support, right? Increase the pressure support up to 11. We're going to achieve at least initial flows that are much more appropriate for the patient, and a patient with much less effort during that inspiratory time. And finally, recognizing this is a patient with COPD. Sorry, some waveforms there again. Our pressure is higher than what we had. Adding a little more PEEP to this patient can take away some of the ineffective triggering that we have, and therefore decrease respiratory rate for that effort for that patient, resulting in a much more appropriate pressure support waveform without a lot of patient effort, better patient synchrony. Just finishing up with another waveform. Another patient with influenza. We had a big influenza season last year. Lots of waveforms to copy here. What do we see in this patient? And what I see is a very, very long eye time, nearly a second long, but otherwise really pretty synchronous. And this person may be paralyzed, I don't know, but this person looks pretty synchronous with the ventilator, just a really long inspiratory time. And again, flow set about 49 with that inspiratory time of half a second. And so finally, looking at this patient, what we really see is sorry, my screen is too small for me to see. Again, what we don't see is that shark fin waveform that we would expect to see. And this is a little bit of patient effort here as flow is decreased. Rather than the shark fin, we see flow being pulled down just a little bit in this patient. And that really is another example of flow asynchrony, which we know is injurious tidal volumes to at least part of that person's lung, and something that should be fixed by increasing that person's flow up to a more physiologic or more acceptable rate for that patient, again resulting in that shark fin shape that we're used to seeing. Sorry about the graphics. All right, so in conclusion, asynchrony is increased work of breathing, something that we should try to get rid of, because asynchrony, especially flow asynchrony, can contribute to lung injury in our patients. Over-reliance on arterial blood gases can actually distract us from the real goals of our patients. They can confuse us and frustrate many people not understanding what the goals of ventilation are. Our waveforms actually provide much more useful information about how to safely manage our patients than a blood gas does. And ventilator adjustments fix asynchrony much better than sedation itself. Questions? Quietness.
Any questions?
Justin.
Kevin, you talked about how diaphragm dysfunction leads to worse outcomes. So can you talk about how long what you're thinking as far as overdriving somebody, how long you would overdrive somebody before you start to worry about diaphragm dysfunction?
So by overdriving, we're talking about increasing the ventilator delivery, increasing minute ventilation. And so that could result in a passive patient for a long period of time, and therefore diaphragm atrophy. Yeah, it's a good question that no one really knows the answer, because we do know that in 100% passive patients, again, something that I haven't shown here, we actually did a study, looked at normal lung brain dead patients that were going to lung harvest, and they actually did biopsies of their diaphragms, and within 18 hours of complete passive ventilation, because the patient's brain dead, there were changes in muscle fibers within 18 hours. And so we know having a completely passive patient really takes a very little time before there's diaphragm changes. And then that's balanced with the injury that occurs from dyssynchrony, and we don't know the answer to that. you know, the other information that we have is ARDS patients, early ARDS with a PF ratio less than 150, cisatracurium for 48 hours was shown to improve mortality. So even though there may be diaphragm dysfunction in those 48 hours because of passive ventilation, decreasing the asynchrony and decreasing the inflammation that goes with it is probably more important than the diaphragm atrophy that goes with it. So I don't know is a short answer, but probably the 48 hours of passive ventilation is probably better than significantly asynchronous ventilation.
So any other questions?
None.
Well,
All right.
thank you very much.
Thank you.